The neonatal hemostatic system represents a balanced but immature system that differs significantly from adult hemostasis. Understanding these developmental differences is crucial for interpreting laboratory values and managing bleeding disorders in neonates. Platelet basics demonstrate that neonates have normal platelet counts of 150,000 to 450,000 per microliter, similar to adults. However, neonatal platelets exhibit functional differences. They are hyporeactive in vitro, showing decreased aggregation responses to adenosine diphosphate, epinephrine, collagen, and thrombin. This hyporeactivity results from fewer alpha-2 adrenergic receptors, impaired calcium mobilization, and reduced expression of protease-activated receptors. Despite this hyporeactivity, neonates maintain normal to enhanced primary hemostasis due to compensatory mechanisms. Higher concentrations of von Willebrand factor, particularly ultra-large multimers, along with higher hematocrits and mean corpuscular volumes, effectively counteract the platelet dysfunction. Coagulation proteins show distinct developmental patterns. Vitamin K-dependent factors 2, 7, 9, and 10 are reduced to approximately 50% of adult values. Contact factors 11 and 12 are similarly decreased, while factors 5, 8, and 13 remain within normal adult ranges. Fibrinogen concentration is normal, but exists in fetal form during the first 3 weeks of life. The balance is maintained through compensatory mechanisms. Lower anticoagulant proteins like antithrombin 3 and protein C offset the decreased procoagulant factors. Higher levels of alpha-2 macroglobulin provide additional anticoagulant capacity. This delicate balance prevents bleeding while allowing normal vascular development. Gestational age effects are more pronounced in preterm infants, who have lower factor levels and more prolonged bleeding times. Adult values are gradually achieved by 6 months of age, as the hemostatic system matures. Using age-specific reference ranges is absolutely critical in neonatal practice, as neonatal coagulation values differ significantly from adult values. The failure to use appropriate reference ranges leads to misinterpretation of laboratory results and inappropriate clinical interventions. The intrinsic pathway demonstrates marked prolongation of activated partial thromboplastin time in neonates, reflecting the reduced levels of factors 11 and 12 and contact factors. This prolongation is physiologic and does not indicate bleeding risk in healthy neonates. The extrinsic pathway shows minimal prolongation of prothrombin time, as factor 7 levels, while reduced, are sufficient for normal function. The common pathway maintains adequate function despite lower levels of factors 2 and 10. Prothrombin time and partial thromboplastin time values are higher in neonates, especially in preterm infants. Term neonates typically have PT values 13 to 15 seconds and APTT values 40 to 50 seconds, significantly longer than adult values. Preterm infants show even greater prolongation, with PT values up to 16 seconds and APTT values up to 60 seconds. Factor levels vary by gestational age, with more immature infants having lower levels. Vitamin K-dependent factors are most affected, reaching only 40 to 50% of adult levels in preterm infants. This developmental pattern reflects the gradual maturation of hepatic synthetic capacity. The clinical pearl emphasizes never using adult normal values in neonates. A PT of 15 seconds would be abnormal in an adult, but completely normal in a term neonate. Similarly, an APTT of 50 seconds represents normal neonatal physiology, not coagulopathy. Understanding these developmental differences prevents unnecessary interventions, inappropriate administration of blood products, and misdiagnosis of bleeding disorders. The neonatal hemostatic system, while immature, is carefully balanced and functional for the unique physiologic needs of the developing infant. Thrombocytopenia in neonates results from 3 primary mechanisms, each with distinct pathophysiology and clinical implications. Understanding these mechanisms guides diagnostic workup and therapeutic interventions. Decreased production occurs when the bone marrow fails to generate adequate platelets. Congenital causes include thrombocytopenia absent radii syndrome, where megacacrocytes are present but defective, and Wiskott-Aldrich syndrome, an X-linked immunodeficiency with small, dysfunctional platelets. Acquired causes involve bone marrow suppression from sepsis, which impairs megakaryocyte maturation, or drugs that interfere with platelet production pathways. Increased destruction represents the most common mechanism in critically ill neonates. Immune destruction occurs when maternal antibodies cross the placenta and target fetal platelets. In neonatal alloimmune thrombocytopenia, maternal antibodies react against paternal platelet antigens like HPA-1a. Maternal ITP involves maternal autoantibodies that also destroy fetal platelets. Non-immune destruction occurs through consumption during DIC, where thrombin generation leads to widespread platelet activation and consumption, or through mechanical destruction in sepsis and necrotizing enterocolitis. Sequestration involves platelets being trapped in enlarged organs, removing them from circulation despite normal production. Hypersplenism causes pooling in an enlarged spleen, while Kasabach-Merritt syndrome involves consumption within vascular malformations where abnormal endothelium activates platelets and coagulation cascades. The most common cause of thrombocytopenia in the NICU is bleeding, which often reflects underlying consumptive processes rather than primary platelet disorders. This highlights the importance of treating underlying conditions rather than focusing solely on platelet transfusion. The timing of thrombocytopenia onset provides crucial diagnostic information reflecting different underlying pathophysiologic processes. The 72-hour cutoff distinguishes conditions present at birth from those acquired postnatally. Early onset thrombocytopenia, occurring within 72 hours, divides into well-appearing versus sick infants. Well-appearing infants most commonly have placental insufficiency from maternal pregnancy-induced hypertension or intrauterine growth restriction. This mechanism involves impaired placental function, leading to fetal hypoxia and reduced megakaryopoiesis. The thrombocytopenia is typically mild to moderate, reaches its nadir around day 4, and resolves within 10 days. Severe early onset thrombocytopenia in well infants suggests immune-mediated destruction, particularly neonatal alloimmune thrombocytopenia. This represents the platelet equivalent of hemolytic disease of the newborn, where maternal antibodies against paternal platelet antigens cause rapid platelet destruction. Unlike maternal ITP, NAIT can occur in first pregnancies and carries higher risks of severe thrombocytopenia and intracranial hemorrhage. Sick infants with early onset thrombocytopenia require evaluation for sepsis, DIC, and chromosomal abnormalities. Early onset sepsis, particularly from Group B streptococcus or E. coli, triggers inflammatory cascades that suppress platelet production and increase consumption. DIC often accompanies sepsis, creating a consumption coagulopathy that rapidly depletes platelets. Late-onset thrombocytopenia, occurring after 72 hours, most commonly results from sepsis and necrotizing enterocolitis. These conditions represent the leading causes of acquired thrombocytopenia in the NICU. Bacterial or fungal sepsis triggers inflammatory mediators that impair megakaryocyte function while increasing platelet consumption through DIC and endothelial activation. Necrotizing enterocolitis creates a particularly complex pathophysiology involving intestinal ischemia, bacterial translocation, and systemic inflammation. The combination of reduced production from bone marrow suppression and increased consumption from inflammation explains the severe thrombocytopenia often seen in NEC. When sepsis and NEC are excluded, consider viral infections like herpes simplex virus, cytomegalovirus, or enterovirus. These viral infections often present with hepatosplenomegaly and elevated liver enzymes, distinguishing them from bacterial causes. Thrombosis, particularly catheter-related, should be considered in infants with central venous access, as enlarging or infected thrombi can consume platelets. Neonatal alloimmune thrombocytopenia represents the platelet equivalent of hemolytic disease of the newborn, affecting 1 in 1,000 to 2,000 births. This condition results from fundamental immunologic incompatibility between maternal and fetal platelets. The pathophysiology begins when the fetus inherits paternal platelet antigens that the mother lacks. The most common trigger is human platelet antigen 1A, accounting for 80% of cases. When fetal blood containing these foreign antigens enters maternal circulation, typically during pregnancy or delivery, The maternal immune system recognizes these platelets as foreign and produces IgG antibodies. Unlike Rh disease, NAIT can occur during the first pregnancy because platelet antigens are more immunogenic than red blood cell antigens. The maternal antibodies cross the placenta and bind to fetal platelets expressing the paternal antigens. These antibody-coated platelets are rapidly cleared by the fetal reticuloendothelial system, primarily in the spleen and liver. The antibodies also suppress megakaryopoiesis, causing decreased platelet production in addition to increased destruction. This dual mechanism explains the severe thrombocytopenia that can develop rapidly and persist despite ongoing platelet production attempts. Clinical presentation typically involves severe thrombocytopenia at birth, often with platelet counts below 50,000 per microliter. The maternal platelet count remains normal, distinguishing NAIT from maternal ITP. The most feared complication is intracranial hemorrhage, occurring in 10 to 20% of cases. Intracranial hemorrhage in NAIT often appears as parenchymal rather than intraventricular bleeding, distinguishing it from hemorrhage due to other causes. This pattern reflects the severe thrombocytopenia and the timing of bleeding, which can occur in utero. Up to 75% of intracranial hemorrhages occur before birth, emphasizing the importance of antenatal recognition and management. NAIT represents the most common cause of severe thrombocytopenia and intracranial hemorrhage in term neonates, making early recognition and appropriate management essential for preventing devastating neurologic consequences. NAIT management requires immediate, systematic intervention to prevent catastrophic bleeding, particularly intracranial hemorrhage. The approach emphasizes rapid platelet transfusion while arranging for more specific therapy. Immediate intervention focuses on platelet transfusion for counts below 30,000 per microliter or below 50,000 per microliter with active bleeding. The severity of thrombocytopenia and bleeding risk guide transfusion thresholds, with lower thresholds acceptable only in stable infants without bleeding. First-choice therapy has evolved to favor random donor platelets as first-line treatment. While these platelets carry the offending antigen and may be rapidly destroyed by circulating antibodies, they provide immediate hemostatic support and are readily available. This represents a shift from previous recommendations for antigen-negative platelets as initial therapy. If available, maternal platelets offer superior compatibility since they lack the offending antigen. However, maternal platelets require processing through washing and irradiation to remove maternal antibodies and prevent graft versus host disease. This processing takes time that may not be available in emergency situations. HPA-matched platelets provide optimal therapy but require specialized blood banking capabilities and may not be immediately available. Some European centers maintain stocks of HPA 1b, 1b platelets specifically for NAT cases. Adjunctive therapy includes intravenous immunoglobulin at 0.5 to 1 gram per kilogram over 2 hours. IVIG may reduce antibody-mediated platelet destruction and improve platelet survival, though its efficacy in acute management remains debated. Essential diagnostic evaluation includes head ultrasound to rule out intracranial hemorrhage. The presence of ICH elevates target platelet counts above 100,000 per microliter and intensifies monitoring requirements. Future pregnancy management involves maternal IVIG therapy beginning at 12 to 26 weeks gestation, depending on the severity of previous cases. Elective cesarean delivery may reduce trauma-related bleeding risks during delivery, though this remains controversial given that most ICH occurs in utero. Maternal ITP represents a distinct form of immune-mediated neonatal thrombocytopenia that differs significantly from NAIT in its pathophysiology, clinical course, and prognosis. Understanding these differences is crucial for appropriate management and family counseling. The mechanism involves transplacental passage of maternal IgG antiplatelet autoantibodies. Unlike NAIT, where antibodies target specific paternal platelet antigens foreign to the mother, maternal ITP involves autoantibodies directed against the mother's own platelet antigens. These same autoantibodies cross the placenta and attack fetal platelets, which share the same antigens as maternal platelets. The incidence affects up to 25% of mothers with primary or secondary ITP during pregnancy. This relatively high transmission rate reflects the fact that maternal and fetal platelets share identical antigens. making all fetuses potentially susceptible rather than only those inheriting specific paternal antigens. Maternal ITP carries significantly lower risk than NAIT. Severe thrombocytopenia occurs in less than 15% of affected neonates, and intracranial hemorrhage risk remains below 2%. This reduced severity likely reflects differences in antibody affinity, concentration, or the specific antigens targeted. The timing pattern shows platelet count naters occurring between days 2 to 5 after birth, typically resolving by day 7. However, unlike NAIT, which usually resolves within 2 weeks, maternal ITP can persist for weeks to months, requiring long-term monitoring and sometimes repeat IVIG treatments. Predictors of neonatal involvement include low maternal platelet counts, below 50,000 per microliter at delivery, and history of severe neonatal thrombocytopenia in previous pregnancies. Importantly, there is poor correlation between maternal platelet counts and severity of neonatal thrombocytopenia, making prediction challenging. The duration may extend for months, distinguishing it from NAIT. Recent reports describe persistent thrombocytopenia caused by IgA antiplatelet antibodies transmitted through breast milk, explaining some cases of prolonged thrombocytopenia. Management focuses on IVIG as first-line therapy, with random donor platelets reserved for active bleeding. Unlike NAIT, maternal platelets offer no advantage since they carry the same antigens being targeted by the antibodies. Cranial imaging is recommended for platelet counts below 50,000 per microliter. Prenatal management differs markedly from NAIT. Cesarean section provides no benefit for fetal thrombocytopenia, and mode of delivery should be determined by obstetric indications alone. Interventions that increase bleeding risk, such as vacuum extraction or forceps delivery, should be avoided. This table helps differentiate alloimmune from autoimmune thrombocytopenia, key for accurate diagnosis and management. The main distinction lies in antibody targets. In NAIT, maternal antibodies attack paternally inherited fetal platelet antigens that the mother lacks. In maternal ITP, maternal autoantibodies target antigens found on both maternal and fetal platelets. This explains why maternal platelets are therapeutic in NAIT, but not helpful in ITP. In NAIT, fetal platelets have unique antigens. In ITP, those antigens are shared. Antigen specificity also differs. NAIT usually involves HPA-1a, while ITP targets glycoproteins like GP2B3A or GP1B9. Severity and timing help distinguish the two. NAIT presents at birth with severe thrombocytopenia, while ITP is usually milder and may worsen gradually. Maternal history is important. NAIT typically occurs in mothers with normal platelet counts and no autoimmune disease. ITP occurs in mothers with chronic thrombocytopenia or autoimmune conditions like lupus or thyroid disease. Bleeding risk differs. Intracranial hemorrhage is more common in NAIT, up to 15%, often before birth. ITP carries a much lower risk, under 2%. Treatment reflects these differences. Both may receive IVIG and steroids, but NAIT needs matched or maternal platelets. ITP usually only needs transfusion if there's active bleeding. Recovery timelines also differ. NAIT resolves in 2 to 4 weeks as antibodies clear. ITP may last up to 12 weeks and sometimes needs ongoing treatment. Focusing on maternal history, platelet trends, and bleeding severity helps distinguish these conditions and guide appropriate care. Platelet transfusion thresholds in neonates reflect the balance between bleeding risk and transfusion-associated complications. The most restrictive approach uses thresholds of less than 20,000 per microliter for stable preterm infants, less than 30,000 per microliter for unstable preterm infants, and less than 20,000 per microliter for term infants. These conservative thresholds recognize that neonatal bleeding risk correlates more strongly with gestational age under 28 weeks, postnatal age under 10 days, and conditions like necrotizing enterocolitis, rather than absolute platelet count. The least restrictive guidelines recommend higher thresholds, less than 50,000 per microliter for stable preterm, less than 100,000 per microliter for unstable preterm, and less than 30,000 per microliter for term infants. For active bleeding, most guidelines recommend transfusion when platelets fall below 50,000 per microliter, while invasive procedures typically require thresholds above 50,000 per microliter. ECMO patients need higher counts, typically above 100,000 per microliter, due to bleeding risk from anticoagulation and circuit-related platelet consumption. Standard dosing involves 10 to 15 milliliters per kilogram administered over approximately 1 hour, typically raising platelet counts by 50,000 to 100,000 per microliter in the absence of ongoing consumption or destruction. Recent evidence challenges traditional liberal transfusion practices. The landmark PLANET II trial randomized 660 thrombocytopenic neonates to receive transfusions at thresholds of either 25,000 per microliter versus 50,000 per microliter. Unexpectedly, infants receiving the higher threshold experienced significantly more death or major bleeding within 28 days, 26% versus 19%. This finding contradicted the assumption that higher platelet counts provide better hemostatic protection. Disease-specific risk stratification reveals important nuances. Neonatal alloimmune thrombocytopenia carries high bleeding risk, requiring aggressive management, while sepsis-related thrombocytopenia shows different risk profiles. The concept of prophylactic thresholds has been questioned, as observational studies demonstrate poor correlation between platelet count severity and actual bleeding episodes. Perhaps most striking is evidence showing no benefit from maintaining normal platelet counts. Earlier studies comparing maintenance at greater than 150,000 per microliter versus greater than 50,000 per microliter found no reduction in intraventricular hemorrhage with higher counts. This challenges the physiologic assumption that more platelets automatically provide better hemostasis, suggesting that other factors, including platelet function, vascular integrity, and coagulation cascade function, may be more important than absolute numbers in determining bleeding risk. Inherited thrombocytopenic syndromes represent congenital defects in platelet production or survival, often accompanied by functional abnormalities that cause bleeding disproportionate to platelet count. Platelet size provides a crucial diagnostic clue for distinguishing these conditions. Wiskott-Aldrich syndrome presents with characteristically small platelets due to accelerated splenic sequestration. This X-linked condition combines severe thrombocytopenia with immunodeficiency and eczema. The underlying defect in the WAS protein disrupts cytoskeletal organization, leading to both platelet dysfunction and T-cell abnormalities. These infants faced significant bleeding risk alongside recurrent infections and autoimmune complications. Bernard-Soulier syndrome produces giant platelets due to defective glycoprotein IB-NMX5 complex, the receptor for von Willebrand factor. This autosomal recessive condition causes severe bleeding through impaired platelet adhesion to damaged endothelium. The large platelet size reflects compensatory mechanisms attempting to maintain hemostatic function despite reduced numbers. Gray platelet syndrome results from alpha-granule deficiency, giving platelets their characteristic pale, agranular appearance on blood smear. These storage pool defects impair platelet activation and aggregation responses. The key diagnostic pattern involves persistent thrombocytopenia with family history, bleeding severity that exceeds what platelet count alone would predict, and distinctive morphologic features that guide specific genetic testing. Hemophilia represents the most common inherited bleeding disorder presenting in the neonatal period, caused by deficiencies in essential coagulation factors within the intrinsic pathway. The pathophysiology centers on inadequate thrombin generation on activated platelet surfaces, resulting in structurally weak clots susceptible to fibrinolysis. Hemophilia A, caused by factor VIII deficiency, affects 1 in 5,000 males through X-linked inheritance. Hemophilia B results from factor IX deficiency, occurring in 1 in 30,000 males. Both conditions show similar clinical presentations but differ in their neonatal diagnostic challenges. Factor VIII levels remain elevated during the neonatal period, making mild hemophilia A diagnosis difficult until 6 to 12 months of age. Conversely, factor IX levels are physiologically reduced at birth, particularly in preterm infants, complicating mild hemophilia B diagnosis. Laboratory evaluation reveals isolated prolongation of activated partial thromboplastin time with normal prothrombin time, platelet count, and fibrinogen levels. Specific factor activity assays provide definitive diagnosis. Neonatal management focuses on prevention through avoiding intramuscular injections, using subcutaneous vitamin K, and maintaining high suspicion for intracranial hemorrhage. Approximately 70% of hemophilic infants are diagnosed within the first month, typically following excessive bleeding after circumcision or during routine procedures. The hemostatic system in neonates differs significantly from adults, with most coagulation factors at 30 to 60% of adult levels, making interpretation of factor levels crucial for accurate diagnosis. Von Willebrand disease represents the most common inherited bleeding disorder overall, yet neonatal presentation remains paradoxically rare due to unique physiologic differences between neonates and adults. The underlying pathophysiology involves defects in von Willebrand factor, a crucial multimeric protein responsible for platelet adhesion to damaged endothelium and serving as the carrier protein for factor VIII. Normal hemostasis requires von Willebrand factor to facilitate initial platelet adhesion, followed by platelet aggregation and stable clot formation. In von Willebrand disease, this process fails, leading to prolonged bleeding from mucosal surfaces and after procedures. The effectiveness of von Willebrand factor depends on its multimerization into high molecular weight complexes that provide optimal adhesive properties. Neonates possess physiologically elevated von Willebrand factor concentrations and an increased proportion of high molecular weight multimers compared to older children and adults. This natural elevation masks most forms of von Willebrand disease during the neonatal period, explaining why diagnosis typically occurs later in childhood, when von Willebrand factor levels normalize. The classification system includes type 1 disease with partial quantitative deficiency, type 2 disease characterized by various qualitative functional defects, and type 3 disease representing complete quantitative deficiency. Type 3, though representing less than 1% of all cases, is most likely to present in neonates because the severe deficiency cannot be compensated by physiologic elevation. These infants experience mucosal bleeding more commonly than intracranial hemorrhage, distinguishing them from hemophilia A patients despite similar factor VIII deficiency. Management requires von Willebrand factor-containing concentrates for moderate to severe bleeding, while avoiding desmopressin due to hyponatremia risk in neonates. Vitamin K deficiency represents one of the most preventable causes of catastrophic bleeding in newborns. As neonatal practitioners, understanding its physiology helps us recognize why every newborn needs prophylaxis. Vitamin K serves as an essential cofactor for synthesizing clotting factors 2, 7, 9, and 10, plus proteins C and S. Without adequate vitamin K, these factors remain inactive, creating a dangerous coagulopathy. Normally, we obtain vitamin K through dietary intake and bacterial gut flora synthesis, but newborns face unique challenges. Here's what makes neonates particularly vulnerable. First, their gut remains sterile at birth, eliminating bacterial vitamin K production. Second, placental transfer is remarkably poor. Mothers simply cannot provide adequate stores during pregnancy. Third, whatever minimal stores babies receive deplete within hours to days. Fourth, breast milk contains extremely low levels, insufficient for newborn needs. Finally, their immature hepatic system cannot store vitamin K effectively. These deficiencies manifest as vitamin K deficiency bleeding, presenting anywhere from day 1 through 6 months of life. Laboratory findings show an elevated INR with normal PTT. This pattern reflects the vitamin K-dependent factors being affected while other coagulation pathways remain intact. Understanding this coagulation profile helps differentiate VKDB from other bleeding disorders on certification exams. Vitamin K deficiency bleeding presents in 3 distinct patterns, each with unique risk factors and clinical implications. Recognizing these presentations enables early intervention and prevents catastrophic outcomes. Early VKDB occurs within the first 24 hours of life, almost exclusively in infants whose mothers took medications interfering with vitamin K metabolism. Anticonvulsants like phenytoin, warfarin, isoniazid, and rifampin cross the placenta and deplete fetal vitamin K stores. These babies present with serious bleeding, intracranial, intra-abdominal, or intrathoracic hemorrhage. The prognosis remains guarded given the severity of bleeding sites. Classic VKDB manifests between days 2 and 7, typically in breastfed infants who missed prophylaxis. The presentation includes more superficial bleeding, bruising, umbilical oozing, or gastrointestinal bleeding. Without vitamin K prophylaxis, idiopathic cases occur, but the prognosis improves significantly with prompt treatment since bleeding sites tend towards superficial locations. Late VKDB develops between 2 and 12 weeks, exclusively in breastfed infants with either inadequate prophylaxis or underlying malabsorption. Cholestatic liver disease, cystic fibrosis, or chronic diarrhea impair vitamin K absorption despite prophylaxis. These infants present catastrophically. Over 50% suffer intracranial hemorrhage. The mortality and morbidity remain substantial, with many survivors experiencing permanent neurological sequelae. The pathophysiology flowchart illustrates how deficiency of vitamin K-dependent clotting factors leads to the characteristic laboratory findings and clinical manifestations we observe across all 3 presentations. Prevention of vitamin K deficiency bleeding stands as one of our most successful public health interventions in neonatology. The evidence overwhelmingly supports universal prophylaxis at birth. Standard dosing follows weight-based protocols. For infants over 1,500 grams, we administer 1 milligram intramuscularly within the first 2 hours of life. Preterm infants under 1,500 grams receive 0.5 milligrams intramuscularly, with some centers using 0.3 milligrams. Both approaches show effectiveness in preventing bleeding. The timing matters significantly. Administration within the first 2 hours ensures protection before physiologic nadir of vitamin K-dependent factors occurs. Intramuscular injection provides superior bioavailability compared to oral routes, achieving therapeutic levels rapidly and sustaining them longer. For parents refusing intramuscular vitamin K, oral regimens exist but require meticulous compliance. The regimen involves 2 milligrams orally at birth, repeated at 4 to 6 days, then again at 4 to 6 weeks. This multi-dose requirement creates compliance challenges and leaves gaps in protection. Studies consistently demonstrate higher VKDB rates with oral protocols compared to single intramuscular doses. Safety concerns occasionally arise from parents. The evidence conclusively shows no association between vitamin K administration and childhood cancers. Allergic reactions remain exceptionally rare, and injection site complications occur minimally. When counseling families, emphasizing the catastrophic nature of intracranial hemorrhage from VKDB versus the minimal risks of prophylaxis helps guide informed decision-making. When evaluating potential vitamin K deficiency bleeding, laboratory confirmation guides our management approach. The prothrombin time, specifically looking for values greater than 4 times normal, provides our primary screening tool. The international normalized ratio elevation reflects vitamin K-dependent factor deficiency. While the activated partial thromboplastin time remains normal, this pattern distinguishes VKDB from other coagulopathies. For non-life-threatening bleeding, subcutaneous vitamin K administration of 1 to 2 milligrams typically suffices. The subcutaneous route achieves adequate levels for minor bleeding while avoiding intramuscular hematoma risk in coagulopathic infants. Life-threatening bleeding demands aggressive intervention. Fresh frozen plasma at 15 to 20 milliliters per kilogram provides immediate factor replacement. We combine this with intravenous vitamin K, understanding that vitamin K alone requires 4 to 6 hours for factor synthesis. Some centers add prothrombin complex concentrates at 50 to 100 units per kilogram for severe intracranial hemorrhage, though pediatric experience remains limited. The key management principle involves simultaneous factor replacement and vitamin K administration. Factor products provide immediate hemostasis, while vitamin K ensures sustained correction. Post-treatment monitoring includes serial PT and INR measurements to confirm correction and guide additional therapy. Remember that vitamin K overdose cannot occur. Excess simply gets stored or excreted without toxicity, allowing generous dosing when bleeding threatens life. Managing DIC requires addressing both the underlying trigger and supporting the failing coagulation system. Without treating the cause, replacement therapy becomes futile, like pouring water into a bucket with holes. Primary treatment targets the precipitating condition aggressively. For sepsis, broad-spectrum antibiotics within the first hour improve survival. Support failing organs with mechanical ventilation, vasopressors, and renal replacement as needed. The hematologic abnormalities won't resolve until the triggering process stops. Blood product replacement follows specific thresholds. For fresh frozen plasma, administer 10 to 15 milliliters per kilogram when coagulopathy exists. Don't wait for active bleeding. This provides all clotting factors, not just fibrinogen. When platelet counts drop below 50,000, transfuse 10 milliliters per kilogram. For active bleeding or procedures, maintain platelets above 100,000. Cryoprecipitate addresses severe hypofibrinogenemia, 1 unit per 5 kilograms body weight when fibrinogen falls below 100 milligrams per deciliter. Each unit provides concentrated fibrinogen, factor VIII, factor 13, and von Willebrand factor. Consider heparin for purpura fulminans cases where thrombosis predominates over bleeding. This seems counterintuitive. Anticoagulation during bleeding? But interrupting thrombin generation can restore hemostatic balance. Serial laboratory monitoring every 6 to 12 hours guides ongoing replacement. Watch fibrinogen levels and platelet counts as markers of consumption severity. Remember, normal values don't mean DIC resolved. They might reflect aggressive replacement masking ongoing consumption.